Gonna wait a few minutes. So we don't have any more, we don't have any video for Gardner. I don't see you. Hold on. Oh, there you are. Okay. I just had to move a picture. So another girl will be joining you, Kelsey. We'll wait just a few more minutes, okay?
All right. All right. Ouch. Ouch. Okay.
I need more room. Sorry. Lost my pen. Here we go. Oh, ended. Why the call? Let's go. All right. What's going on now?
All right, ladies. Can everyone hear me okay?
Yep.
Already called
All right.
back.
Okay. How was homework for everyone?
It was good.
How the hell is this thing alive?
Okay. We went over last week, actually this is week 3 for coding. Last week we covered chapters 5 through 8. So this week we're going to be doing 9 through 12. And I think for answers, I asked everyone just to do the even numbers. Is that correct?
Yeah.
Oh,
Okay.
can they hear me?
Yes, I can hear you, Kelly. Okay. So let's start with page.
Call back.
Okay, I can hear you. But go ahead, call back if you need to.
Oh,
All right, so let's start on page 64 on chapter 5. And we'll go over some of the answers. All right, number 2. After the patient visit, information from the record is transmitted to the insurance company in the form of what? What do you think, Kelsey?
Claim.
Yes, it is a claim. All right, and number 4, name the 2 basic claim submissions. What are, can you hear me, Kelly? Okay, for number 4, the answer would be electronic or paper. All right, page 66. 66, number 2. We want to name the important legislation Congress passed in 1996 that significantly impacted medical billing and claim submission. That would be the Health Insurance Portability and Accountability Act, HIPAA. Number 4, what are the 4 exceptions to ASCA's electronic claim submission requirement? You will find that these are listed in your text. It is roster billing of Medicare covered vaccinations, dental claims, claims where there are 2 or more primary plans and Medicare is secondary, and service interruptions beyond the control of the provider. Number 6 is true or false. The answer is false because the NPI is unique. Kelly, you're having trouble?
Now what?
Okay. Let's turn to page 71. Page 70, actually. Sorry. Number 2, list the entities that are affected by the switch to the new HIPAA standards. That would be the book list physicians, the hospitals, ancillary care and behavioral health providers, your third-party payers, claims clearinghouses, pharmacies, and dentists. Others would include vendors, billing services, and laboratories. Okay. Number 4, the ASCA requires that all claims submitted to Medicare program be submitted in electronic form, no exceptions.
That's false because there are some exceptions, right?
Correct. Correct. Hey, Kelly.
Hello. Sorry.
That's okay. Are you wireless?
No, I'm plugged in.
Okay. All right. So page 79 in your textbook. Number 2, list the information and documents essential for claims processing. It would be your patient information form, your insurance ID card, the patient's health and medical record, encounter form and ledger card. Number 4, what types of information are typically included on an encounter form? Demographic, accounting, professional services, rendered procedure codes, professional fees, return appointment information, frequently used diagnosis codes. Page 81. What are the 2 advantages of submitting claim forms electronically? Kelsey, can you tell me what that might be?
Improves cash flow and streamlines internal processing or processes. Allows them to focus more on patient care.
Yep. And then number 4, which of the 2 electronic submission processes, clearinghouse or direct, is better? The answer would be if the practice submits insurance claim forms to multiple carriers and has someone who is well trained technically to handle the task of electronic claim submission, an electronic claims clearinghouse might be the better choice. If claims are sent primarily to one carrier, the practice should consider using direct submission to that carrier. Number 2, true or false? What do you think, Kelly?
What page?
Page 84,
here we
number
go.
2.
Okay. That's false.
Correct. All right, number 4, paper claims can be tracked using a follow-up system such as insurance log or an insurance register. And number 6, name 2 categories of providers who can use the CMS 1500 paper form. A small provider billing a Medicare fiscal intermediary that has fewer than 25 full-time equivalent employees, and a physician practitioner or supplier with fewer than 10 FTEs that bills a Medicare carrier. And that takes care of Chapter 5. Let's move into Chapter 6. Actually, any questions on Chapter 5 at all?
No.
Not yet. No.
Okay. All right, page 91. Number 2, how is a lifetime maximum cap different from an insurance cap? A maximum lifetime cap is the amount that is stated in the policy after which your insurance company will not pay any more of the medical charges incurred. A lifetime cap is typically quite high, usually $500,000 to $1 million. Your insurance cap maximum amount is that the policyholder has to pay out of pocket for any one incident in any one year. Under the new Healthcare Reform Act, there are lifetime limits on most benefits that are prohibited in health plans or insurance policies issued or renewed on or after September 23rd, 2010. There is no annual dollar limits that are allowed on most of your covered benefits beginning January 1st, 2014. Number 4, what 3 things does the RVS take into consideration when establishing fees? Kelsey, what do you think?
The work done by the physicians, cost of malpractice insurance, practice expenses like salaries, overhead, and supplies.
Yes. Okay, let's turn to page 92.
And actually, it skipped number 2 on page 90, and I'm not sure if I got that one right.
Oh, how did I do that? Oh. Oh, I did, didn't I? Okay. What main advantage, on page 90, number 2, what main advantage does an individual or private insurance offer? Basically, it's autonomy and flexibility of choices. Thank you for catching that.
Yeah.
Okay, so then let's turn to page 92. Number 2. What impact did the Affordable Care Act have on pre-existing conditions? The Affordable Care Act changed the pre-existing condition requirements. It began in 2014, where the pre-existing condition exclusion factor is no longer applicable. So your insurance company can't turn you down or charge you more because of your condition. Number 4, explain the expression grandfathered. Kelly, can you explain that to me?
The grandfather doesn't it mean that by the time it's I can't remember. Grandfather is
you're on the right track. I know what you're talking about.
It's already been when you've already been insured and the time has passed by, they can't change anything.
Correct. You're along that line, exactly. So grandfathered means to an exempt individual or business from new regulations. So if a new law restricts the size of billboards along a highway to no larger than 4 by 6 feet, but it allows or grandfathers larger ones that were erected prior to the passage of that law, they can remain. So you were definitely on the right track. Good job.
Okay. Thank you.
Okay. Page 94. 94, number 2. List the services included in the minimum health care coverage mandate. There's a whole list of them. Okay. Ambulatory.
Oh, it's right here.
Emergency.
You're visiting? Just visiting?
No.
Or you're taking? Oh, I think it starts at 5:30. Just so you know.
I thought it was 6.
Hi.
Hi, Anita.
Hi, Doreen. How are you?
But her
I'm
screen is
good. How are you?
Good, I'm doing good. I thought it's 6 o'clock.
That's okay. I knew you were coming.
Yeah.
Kelsey can show you where we're at.
page 94.
94.
We're on these here.
Yes.
Okay. So for number 2 on page 94, ambulatory, emergency, hospitalization, maternity and newborn care, mental health and substance abuse disorder services. This is going to include behavioral treatment, prescription drugs, rehab, and habilitative services and devices, your laboratory services, your preventative and wellness services, chronic disease management and pediatric services, including oral and vision care. And you might have access to this information on the computer underneath healthcare.gov. If you type in minimal essential coverage, it will basically give you a listing of the mandatory services. And if you go to cms.gov website, the same thing. Type in minimal essential coverage in the search box, and it will give you a list. All right, number 4. Explain the difference between traditional insurance and self-insurance. So what is traditional insurance, Kelly?
Traditional insurance is the insurance that, like Blue Cross and Blue Shield, ones that have been out there for a while. Is that?
Yep. Okay, and then
Blue Cross,
self-insurance.
Blue Shield.
What is self-insurance, Kelsey?
I don't know if I got this one right, but I wrote down the employer, not the insurance company, is responsible for the cost of medical services.
Correct. Exactly. Yep.
Okay.
All right. And number 6, how might a single or specialty service plan benefit an employee? This is what we call a carved out plan, where it will provide payment for services that are specifically for certain areas of coverage. So that could be mental health, vision, dental expenses, usually a single or specialty service where it helps to benefit the employee by offering coverage in these other areas that aren't usually covered by your regular health insurance. All right, let's turn to page 99. Number 2, explain the Blue Card program. All right, the Blue Card program. This links your independent Blue plans so that your members and families can obtain health care services while they travel or work anywhere. And to help us identify those who participate in those Blue Card programs, the health insurance professional should look for that suitcase logo on their ID card. So if the member does belong to one of these, it will indicate a little PPO up in the suitcase, okay? All right, number 4. What role does Blue Cross and Blue Shield play in the FEP program? Kelsey, you want to take a stab at that one?
Blue Cross Blue Shield basically underwrites and administers plans, and they work with the personnel management to do that for
Yes.
the management of other companies. Is that right?
Yes. Yep. Okay. Okay, and then over on the right-hand column, number 2, what special benefits does Blue Cross Blue Shield extend to their PAR providers? Usually, under this contractual agreement, Blue Cross and Blue Shield will agree to send payments directly to your provider, host periodic staff training seminars, offer guides and newsletters at no charge, provide assistance with claim problems, and publish the practices information in the Blue Cross and Blue Shield PAR directory. All right. Over on 100. If the provider's office is set up for electronic claims filing, how can the health insurance professional find out if his or her facility is compatible with the carrier's electronic standards? What do you think, Kelly? Okay. Anita, you want to take a stab at that?
I think it comes through clearinghouse on X12 file.
Yes. So we would contact the carrier before we submit the claims, and we ask them what format they would prefer or what format they would use. All right, number 4, name the document that guarantees claims reach the payer and clearinghouse on time. That would be the electronic claims receipt report. All right, and that should be it for chapter 6. Yes?
There's one more.
Oh, that's right. Page 103. Number 2, what is the purpose of the EOB? Kelsey, what is the purpose of the EOB?
It gives the details of how the claim was decided or determined.
Yep. It basically lists out everything, right? Insurance
Yeah.
information, patient data service, payments, reasons, all that stuff. Any questions on chapter 6?
No.
All right. Anita, any questions?
No, thank you.
Okay. All right, then let's go to chapter 7. Page 107, number 2. How did managed healthcare get started here in the U.S.?
I didn't get an exact answer for that one.
Well, basically in the 1970s, there was a growing concern within our general population of how the individuals in the U.S. had to pay for good health care. So this is where they came up with some ideas of controlling or managing those costs. That's how it became managed health care.
Okay.
All right, page 110. Number 2, explain how a PPO works. Anita, what do you think?
Yeah, PPO is like preferred provider organization. You have you can, without primary physician, you can directly, you have a choice to go to specialist, and there's the cost may be more because it's loosely controlled.
Yep,
That's what.
that's good. Good work. Excuse me. All right. Number 4, what is the function of a PCP, Kelsey?
They oversee the patient's total health care treatment.
Right. They take care of they oversee the member's total health care treatment, and they must authorize any visits that go to the PCP, so your referrals and your consultations.
Yeah.
All right, page 111. Number 2, list and explain the disadvantages of managed care. So, tell me about limited provider pool. What is a limited provider pool? Kelly, we're on page 111, number 2.
I'm sorry, it's my internet. We're planning on getting a new internet system. It keeps shutting down for some reason. I am
That's
very,
okay.
very sorry. Okay. Are you waiting for me?
Yep, I asked Anita what limited provider pool is.
Oh,
Oh,
I'm so sorry.
you asked me. Okay. Under managed care, you get HMO. That's like fee for service and PPO.
Yep.
And you have less choice of providers within a network.
Yep. Good. What is restricted coverage, Kelsey?
You have to wait for your PCP to basically okay to see a specialist.
Yep. And prior approval needed. If a member wants to see a specialist, authorization is needed from the PCP. So these are two are really close here. Restricted coverage is where the PCP must first justify the need based on the benefit. The prior approval needed is the PCP needs to authorize it before the patient gets it. So 2 different things there. Just pay attention to what the difference is, okay? And then the 4th one, possibility of undertreatment, because your HMOs typically give doctors financial incentives to limit care. Some doctors have been known to hold back on the treatment he or she gives their patients. And then compromised privacy is HMOs use patient records to monitor doctors' performance and deficiency, so details of the member's medical history will be seen by other people, which may breach the patient's right to privacy. So just be careful. All right, in the right-hand column on page 111, number 2, identify the type of care predicted to be best suited for managed care. What do you think, Kelly?
To be predicted for managed care, type of care. For managed care. Medicaid? I'm not sure if I got this one right or not.
Okay, this is where
the MCOs?
yes, this is where the focus is said to be actually on the capitated managed care, in which your states will hire a managed care organization, so yes, MCO, to run the program and assume most of the risk for caring for the people. The experts claim that managed Medicaid long-term services and supports in particular offer better patient care along with greater ability to control costs.
Okay.
That's the long-winded answer. All right, page 113, number 2. Name the organizations from which MCOs typically receive their accreditation. Kelsey, can you do that one for me?
The National Committee for Quality Assurance, Joint Commission, and Utilization Review Accreditation Commission.
Yes. And also the National Committee on Quality Assurance. Number 4, what is a utilization review? Anita?
I got confused with prior authorization and utilization review. What's the difference?
Your utilization review is a system that is designed to determine the medical necessity and the appropriateness of a requested medical service or procedure or a hospital admission before the concurrent or the retrospective to the event. So a utilization review is really narrowing down, did this patient really need this service, or do they really need this service, and can we go ahead and approve it? Or if they approved it, was it on the up and up? Did that help?
Yeah.
Okay.
Even prior authorization is same as utilization, right? Prior authorization before the service there.
Okay, prior authorization versus utilization. Prior authorization is something that is required based on insurance benefits. It's not necessarily part of the utilization review. Prior authorization has to do when we verify insurance benefits and we find out is the patient covered for this service, and if so, is there pre-certification or prior authorization required? That would be the difference between prior authorization and utilization review.
Yeah.
All right.
Yeah.
Okay. Page 116. Number 2. List some of the typical things that a plan's representative will take into consideration when pre-certifying a procedure and or service. Kelsey, what did you have for that one?
Well, I think I wrote down the wrong numbers, but I think this is the right one. So basically with the doctor's notes and lab results, and depending on what your plan covers, and whether the procedure is medically necessary and appropriate.
Okay, so some of the things that you would take into consideration when you're pre-certifying a service. You want to make sure that you have the members' eligibility and benefits in accordance with those plan documents. Determine if they have coverage for inpatient admissions and any selected ambulatory services. Also, assess the appropriateness of the proposed site of service. So is it going to be done in the office or in the ambulatory surgery? Also identify if there are alternatives to the proposed care or site of service when it is appropriate. Identify and refer to case management programs when appropriate. So if you have a surgery or someone who has been in trauma, you want to make sure if they need any further ongoing case management. Identify and any quality of care issues and refer them for review. This is where our utilization review might come in. And then identifying and documenting any potential coordination of benefit, subrogation, or workers' compensation information. So when you're pre-certifying a procedure and service, it all depends on where or what you are pre-certifying. What do you take into consideration when you are doing this? So what I just said to you, what I just listed for you, is more involved. Sometimes it can be as simple as, okay, the patient's coming in for chiropractic care. Do they need permission or authorization for an x-ray? Can the doctor do it in the office, or does he have to send them out? It can be that simple. It doesn't have to be as involved as those answers I just gave you preceding, okay? Just keep in mind where you are at. All right. Number 4, a referral is the same as a consultation. Kelsey?
What page are you on?
No,
I'm still
it
on
was number 3,
116.
but no, it's not.
Third question.
It was number 3. There's no number 4.
Oh, okay, that's why I was confused. So you want number 3 on
Yeah.
page 116?
Yes.
Oh. I
Yeah,
have
there's
that
no number
as
4.
4. Well, that stinks.
Unless it's
It's
somewhere
not a
else.
number 4. So,
Oh,
okay. Nope, we don't need to
I'll
answer.
still answer it if you want.
True
I
or
was just
false?
confused.
Is it true or false?
True. Right?
A referral is the same as a consultation.
no.
Correct, it's false. All right. 118, number 2, true or false, Anita?
Now, 180. List 4 areas of health.
Number 2, true or false? Number 2.
True. True.
Yes, that is correct. Number 2 is true. Okay.
Oh, okay.
On page 120, number 2, what do you think is meant by the statement, managed care is still evolving and is very much a work in progress? And this is actually an opinion. What is your opinion on this? I'm going to ask all of you. Kelsey, we'll start with you.
Okay. I think it just is basically saying that since healthcare is always changing and things like technology and like what doctors know and all that, that's always changing. So it's always going to be evolving and always going to be a work in progress.
Right. How about you, Kelly?
Managed, I have to actually agree. I agree. I mean, everything's changing, technology. By next year, everything's probably going to be even more thought out. The doctors and doctors are going to be a little bit more knowing what everything is. Everything's going to be evolving more and more as time goes by.
Yep.
We're going to improve on everything.
Yes. What do you think, Anita?
Yeah, it's managed care is still evolving because it, like in the beginning it was in the paper claim, now electronic, and recently Affordable Act has come up. So maybe there might be a lot of changes in future too.
Yes. Okay. Any questions on Chapter 7, ladies?
No.
No.
All right. Move on to chapter 8. Page 125. Number 2. When was the Medicaid program established? Kelly.
1965.
Yes. Okay, number 4.
Okay.
True or false? Number 4, true or false? Kelsey.
False.
Yes.
False. Oops.
Yep.
Sorry.
Yeah.
Okay, page 129. Number 2. What federal department is charged with determining whether a state is in compliance with Medicaid benefit and eligibility standards? What department do you need that?
CM, Center for Medicaid and Medicare Services.
It's the Department of Health and Human Services, DHHS.
HS, yeah.
Okay. Number 4, true or false? States must accept the Affordable Care Act's provision that expanded Medicaid to all Americans under age 65 whose family income is at or below 133% of the family poverty level by January 1st, 2014. What is your answer, Kelsey?
I said false with a question mark.
It is false. Very good. Okay, and all right, and then number 6, what special groups are eligible for SSI? That would be an individual must be at least 65 years old or blind or disabled and must have limited assets or resources. Let's turn to page 131. Okay, number 2. What is TANF? Kelsey, what is TANF?
Temporary cash assistance for needy families.
Yes. Yep. Number 4. Identify at least 3 population groups that fall into each of the 2 main eligibility categories. We have needy. We have medically needy. So your categorically needy are the people meeting, the TANF criteria, children under age 1 and pregnant women whose income meets qualifying income criteria. Your SSI recipients, the medically needy being certain categories of pregnant women, persons 65 years of age or older, disabled or blind under SSA standards. And then number 6, how can an individual spend down so he or she can apply for Medicaid benefits? What do you have for that one, Kelsey?
Basically take your health insurance out of your income so it looks like you're making less.
Yes. Yes. All right. right, let's turn to page 132. Number 2. Name 3 things that the maternal and child health services do. You could have any one of the 3. Reduce infant mortality and incidence of handicapping conditions among children. Increase the number of children appropriately immunized against disease. Increase the number of children in low-income households who receive assessments and follow-up diagnostic and treatment services. Provide and ensure access to comprehensive perinatal care for women, preventative and child care services, comprehensive care, including long-term care services for children with special health care needs, and rehabilitation services for blind and disabled children under 16 years of age who are eligible for SSI. All right, number 4. Name the program that is centered on the belief that the elderly with long-term care needs are better served in their own community. Anitha, what do you think that is?
I didn't read this chapter and I didn't get time.
Okay. The answer would be PACE, P-A-C-E. All right. Sorry. All right. Page 132 on the right-hand column down below. List 4 responsibilities of a Medicaid contractor. That would be processing claims, providing information for healthcare providers for the particular government program involved, generating guidelines for providers to facilitate the claims process and answer beneficiary questions about benefits, claims processing, appeals, and the explanation of benefits, or remittance advice document. Number 1, page 134. Number 2, what types of items are typically included in cost sharing? This would be your co-payments, your co-insurance, and your deductibles. Number 4, true or false, Kelsey?
False.
Yes, false. And number 6, Medicaid recipients cannot be seen in hospital emergency departments. That would be false. On page 135, what criteria does a procedure or service have to meet to be considered medically necessary? That would typically be, it would typically need to be consistent with the diagnosis and in accordance with the standards of good medical practice, being performed at the proper level and then provided in the most appropriate setting. So Kelly, we're on page 135, number 2.
I have a question real quick.
Sure.
Sorry again about my internet. Would I be able to go to the Gardner?
Yeah.
Go to Gardner and
Yeah.
get in on their classroom?
Yes.
Okay. I just need I'm not sure where exactly it is, so I'll need directions. Or do I just call the adult
You
ed?
can just go on Google and Google Gardner Adult Ed.
Okay. All right. Thank you very much.
Yep. Okay, page 137, number 2. Name the 3 ways that Medicaid eligibility can be verified. Patient's eligibility may be verified in the following ways: the patient's medical ID card, the AVR, the automated voice response system, electronic data interchange, EDI, a point of sale device, and a computer software program. Number 4, what are the benefits of the eligibility verification system? By using one of these eligibility verification system methods, providers can reduce the number of denied claims by verifying recipient eligibility and insurance information before services are provided. Upfront verification using eligibility verification system results in the submission of more accurate claims and decreases the eligibility-related claim denial. All right, page 138. Number 2, name 2 categories of Medicare beneficiaries who are eligible for partial Medicaid coverage.
Supplemental medical insurance. Is that one of them?
It can be considered that. What they're looking for is qualified disabled and working individual, qualified Medicare beneficiary, or specified
Low income.
Medicare beneficiaries. All right. All right. Page 139, number 2. A set payment between a state Medicaid agency and an MCO is referred to as capitation. Number 4, name the federal act that will expand Medicaid to reach many additional low-income uninsured Americans. It will be Patient Protection and Affordable Care Act. Page 140. Number 2. What is the time limit for filing Medicaid claims? What do you think, Kelsey?
It depends on the state, but anywhere from 2 months to a year.
Yes. Number 4, define a crossover claim. A crossover claim is the transfer, usually electronic, of claim data from one insurer to another insurer. (141) Number 2, list some examples of third-party entities that would be primary to Medicaid. We're talking about employment-related health insurance, court-ordered health insurance by non-custodial parent, workers' compensation, long-term care insurance, and other state and federal programs unless specifically excluded by federal statute. All right. The second, what did you learn on page 141? Number 2, 5 things that health insurance professional can do to avoid common billing claim errors. Well, follow the guidelines for all of your contractors. Make sure that all of the required blocks are filled completely and accurately. Proofread all the claims. Make sure the claim is signed by the provider. File within the time limit and include any supporting documentation when necessary. On page 142, Number 2, what 2 types of codes typically appear on an RA? What would that be, Kelsey?
Remark and reason codes.
Yes. And on page 144, number 2, 2 methods a provider can use to obtain pre-authorization to perform a service. Kelly?
To provide service.
How can they obtain pre-authorization? What 2 ways might they use?
They have a form like pre-authorization.
Pre-admission, pre-procedure.
Yep, but to fill out that form, they would either have to use the telephone or the internet. Those are the 2 methods that people might use to obtain pre-certification and pre-authorization. All right, on page 145, number 2, what should the health insurance professional do when fraud or abuse is suspected? They should contact the Attorney General's Medicaid Fraud Control Unit if you have evidence or suspect a healthcare provider is committing Medicaid fraud. Page 145, over on the bottom, number 2, what are the 2 responsibilities CMS has under the Medicaid Integrity Program? They show it right in your book on page 145 in the paragraph. Contractors to review Medicaid provider activities, audit claims, identify overpayments, educate providers and others on Medicaid program integrity issues, and to provide effective support and assistance to states in their efforts to combat Medicaid provider fraud and abuse. All right, and on page 146, we weren't doing that one because it's all by itself. Any questions on chapter 8?
No.
No.
All right, so that brings us up to chapter 9, where we will begin tonight. Conquering Medicare's challenges. Let's start on page 151. All right, so what is Medicare? On page 151, what is Medicare? Medicare, if you look down at the diagram on page 151, it is a comprehensive federal insurance program that was established by Congress in 1966. And it is to provide people age 65 and older with financial assistance for their medical expenses. In 1972, the Medicare program was expanded to include certain categories of disabled people under age 65 and those of any age who have end-stage renal disease and permanent kidney disorders that require dialysis or transplant. Who administers Medicare? Medicare is administered by Centers for Medicare and Medicaid Services, otherwise known as CMS. It was formerly called Healthcare Financing Administration. An acronym for that is HCFA, HCFA. We're still on page 151 in your textbook. It is a division of the Department of Health and Human Services, HHS or DHHS. FICA, Federal Insurance Contributions Act. This is a federal system of old age, survivor, and disability insurance. It is financed by Social Security taxes. Medicare is not free. I'm on page 152. Medicare is not free. Your individuals must meet certain conditions to qualify for the benefits, and your beneficiaries are required to pay part of the cost in the form of premiums, deductibles, and coinsurance. And this is basically called cost sharing. The Medicare program structure, you have 4 primary parts. Medicare A, which is your hospital insurance. Medicare Part B is your physician's care. This includes health care provided in clinics. Part C is your Advantage plan. This is formerly called the Medicare Plus Choice. And your Part C plans are managed care type plans. Part D is the prescription drug program. Your Medicare Part A, this helps pay for medically necessary services for your inpatient hospital care, the inpatient care in nursing facility, your home health care, your hospice care, and your blood. Part A also does not cover your custodial or long-term nursing home care. The coverage requirements.
I have a question.
Sure.
What would cover like in-home care, like long-term care? Any of those, or like a hospice or something like that?
That might fall under, well, inpatient care in a skilled nursing facility. That would be Part A. If you look over on underneath on table 9-1, it tells you home health care, other skilled nursing facility care. That would be Part A. And it just tells you how, you know, what Medicare covers and what the beneficiary pays.
Okay, all right. Thank you.
Yep. Keep in mind that your non-covered services are items or services that are not paid by Medicare. Your Part A coverage is free to any individual age 65 who is, and it tells you who is, 65 or older. They receive monthly Social Security benefits. They're free to any disabled individual younger than 65 who might meet the eligibility requirements. Your max or your MACs. This is a private organization that contracts with Medicare to pay A and some Part B bills. You want to determine payment to Part A facilities for covered items. So I'm on page 154, ladies. Your Medicare administrative contractors. You want to determine payment to the Part A facilities for covered items and services provided by the medical facility. Medicare Part B on page 155. It covers your medically necessary procedures and services that are received in the physician's office or clinic. To qualify as a DME, it must be ordered by a physician for use in home, and the items must be reusable: your walkers, your wheelchairs, your hospital beds. As noted, Medicare typically expands services every year. So if you want a complete up-to-date list of covered and non-covered services, type Medicare and you along with the appropriate year in your internet search, and it will come up and give you the most recent publication. Part B Medicare covers a yearly wellness exam for most individuals, as well as other preventative service, so you just have to know what those are. The Part B premium, all of the beneficiaries pay for Part B coverage. The premiums are higher for those beneficiaries whose yearly income is in excess of $85,000 for a single person or $170,000 for a joint. Medicare administrative contractors for Part B. The Part B max will determine the payment of services that are covered under Part B. So the private company that contracts with CMS to provide these claims will process the payment for these Part B services. Enrollment at the bottom of page 155. An individual must decide whether to enroll in Part A or Part B. And once the beneficiary knows what they want, they should contact their local Social Security office 3 months before their 65th birthday. 3 months. For late enrollment, if an individual does not sign up for Medicare Part B when first becoming eligible and they later decide to enroll, your monthly premium will be higher than the basic premium for each 12-month period that you were eligible to enroll, but you did not. So you're almost being penalized for not enrolling early. Premiums and cost sharing requirements. As of 2013, over on page 157, the Part B deductible was $147. I know that today that deductible is still $147. They haven't raised it yet. What is a benefit period for these people? It is the duration of time during which they are eligible for Part A benefits for the services incurred in a hospital or skilled nursing facility. The benefit period ends when the beneficiary has not received care in a hospital or skilled nursing facility. Over on page 158, Medicare Part. These are your Medicare Advantage plans or your MA plans. This is an alternative to the original Medicare. It allows the government to pay insurers to manage the benefits for seniors. These prepaid healthcare plans will offer Medicare Part A and B coverage in addition to coverage for the other services. Your Medicare Advantage plans also are run by private companies that are approved by Medicare. Part C coverage usually includes both A and B, but there are additional services that are not included under the original Medicare. Some of those items might be preventative care, prescription drugs, eyeglasses, dental care, and hearing aids. Some different types of Medicare Advantage plans: the Medicare Managed Care plans, your Medicare Private Fee-for-Service plans, special needs plans, and HMO plans. These are some of the different types. The healthcare reform's impact on Medicare Advantage plans. Your Medicare Advantage plans were designed to save money for the government by operating like HMOs. How this change affects seniors: the premiums may rise, some plans may reduce extra benefits, and some companies may stop offering Medicare Advantage. Other Medicare health plans: your Medicare cost plans, your demonstration and pilot programs, and the PACE. Medicare Part D, over on page 159. Medicare Part D will offer prescription drug coverage to all of our seniors eligible for Medicare. They're run by the insurance companies or other private health organizations that are approved by Medicare. And when the beneficiaries enroll in Part D, they pay an additional premium which varies from plan to plan, and it can be deducted from their monthly Social Security check or paid separately. Some of the Part D benefits you'll see on the top of right-hand column on page 159.
So I have a question.
Sure.
Like Medicare, do they have to pay premiums and also deduct from Social Security?
Yes. Yes, they do.
Which one covers long term? Like A, B, C, D, nothing covers long term.
Well, there's going to be an overlap in both. Part A will pay up to a certain part, and then Part B picks up where the other one won't. Or you can have an Advantage plan that takes care of all that other stuff. It's just determining what the type of care is needed and where it's going to be. If you look at your tables in this chapter, you'll get a better idea for it. Okay?
Sure.
The Affordable Care Act and Medicare Part D, bottom of page 159. In 2013, seniors who hit the donut hole received improved coverage on brand name drugs. The coverage of the generic drugs in the gap will increase from 14% to 21%. So what is a donut hole? A donut hole is the gap between the initial coverage limit and catastrophic coverage. That is what is referred to as the donut hole. All right, dual eligibles and Part D. This is where a person can receive full Medicaid benefits package, but they will lose their prescription drug coverage under Medicaid, but that means that they can then enroll in Medicare Part D prescription drug benefit. So your dual eligibles lose prescription drug under Medicaid, but they can enroll in Medicare Part D to get their prescriptions. Medicare pays the Part D deductible, and then the premiums for the dual eligibles if they're enrolled in an average or low-cost Part D plan. So it's a little confusing, Basically, the person can be enrolled in both plans. That just means that one is going to cover certain things than the other. Your dual eligibles, though, are responsible, however, for small co-payments. PACE program, all-inclusive care for the elderly. Bottom of page 160. PACE provides a community-based acute and long-term care services. The eligibility requirements is that someone is 55 years or older. They must meet the medical need criteria. They live in an area serviced by a PACE organization, and they can be safely served in the community to the PACE organization. Most of your PACE providers or services are provided at what is called a licensed day activity center. Medicare combination coverages. When Medicare is the primary, you will see that it will be the primary coverage, and then they might have a secondary. It might be Medicaid, or you might have supplemental policies, or Medicare might be a secondary payer. It depends on who has the insurance. So let's talk about Medicare and Medicaid dual eligibility. The people who qualify for benefits under both the Medicare and Medicaid programs, Medicare does not pay for all the services. Medicare beneficiaries will have to meet a yearly deductible. They will pay a monthly premium, and then they might have a 20% copayment for all of their covered services. Medicaid does pick up a small amount of that. Your Medigap insurance over on page 161. This is specifically designed to supplement your Medicare benefits. It is regulated by federal and state law. The Medigap policy must be clearly identified as Medicare supplemental insurance. It must provide specific benefits that help fill the gaps in Medicare coverage. Your standard Medigap policies, we have 10 standard plans. Each plan has a different benefit, and Plan A is the basic plan with the least benefits. Medigap eligibility. Over on page 162, Medicare beneficiaries have a 6-month open enrollment period. Your Medicare secondary payer, or MSP, is the term used when Medicare is not responsible for paying first because the beneficiary is covered under another insurance policy. The term that's used when Medicare is not responsible for paying first, when the beneficiary is covered under another insurance policy, would be when they use Medicare secondary payer. You might see this in workers' comp situations. Someone's disabled age 64, but they're under coverage by a larger group health plan. So if we have 2 elderly people, but one is still working and they have health insurance through their job, but the spouse is of Medicare age, even though they're of Medicare age, they're still covered under their spouse's health insurance. So their spouse's health insurance would be primary and Medicare would be secondary. Medicare and managed care over on page 163. The contract with Medicare to pay for services to eligible beneficiaries. This would fill in the gap in basic Medicare, which is similar to the Medigap policies. Your Medicare HMOs, HMO with point of service option. preferred provider organization, your provider sponsored organization, your private fee-for-service plan, and special needs plans. This is an elusive skilled nursing plan, and also it's a disproportionate share for skilled nursing plan, or special needs plan, special needs plan. Some advantages of your Medicare HMOs on page 165. Some of the advantages might be what they list there in your book. Your HMO plans typically provide a managed treatment approach to the care that's designed to minimize unnecessary costs and services. This design will allow the HMO Advantage Plan enrollee to pay a lower premium rate than those that are charged by your traditional Medicare plans. What are the disadvantages? They have those listed over on the right-hand column of page 165. If the enrollee decides to switch from the HMO to the traditional Medicare plan, the coverage does not begin until the first day of the month after the disenrollment request. So what's important for us to know as the health insurance professional is that we are usually the liaison between the third-party payer and the entire healthcare team. So we must be able to answer patients' questions about Medicare accurately, and we must also become an expert on the Medicare beneficiary's perspective. So what are we going to do to prepare the Medicare patient on page 167? When a Medicare beneficiary comes to the office for an appointment, the procedure for handling the encounter is basically the same as with a non-Medicare patient, except a few exceptions. Typically, a release of information is valid for 1 year. However, with your Medicare patients, a one-time, lifetime release of information may be signed by the beneficiary, eliminating the necessity of annual updates. When we are determining medical necessity, there must be criteria that is met. That would be consistent with the symptoms or diagnosis of the illness or injury being treated, necessary and consistent with generally accepted professional medical standards, not furnished primarily for the convenience of the patient or physician, and furnished at the most appropriate level that can be provided safely to the patient. An ABN, or Advanced Beneficiary Notice, on page 168 and 169. In addition to obtaining that valid release of information form, we as the health professional should make sure that the service requested are eligible for Medicare coverage. So it's our responsibility to know if that procedure or service is covered by Medicare, and if it is not, then the ABN needs to be signed by the patient. The medical facility cannot charge the patient. So that page 169, you have an ABN there. In a chiropractic office, we know that x-rays aren't covered. So we have the patient sign an ABN. They choose an option. That means the patient has been made aware of the fact that x-rays are not covered in the office. And when we get the denial, we can turn around and charge the patient for those x-rays. If we do not have an ABN signed by the patient, we cannot charge the patient. Over on page 170, local coverage determination. Most of your Medicare policies are established at the local level, giving your MACs a great deal of authority over payment policy in a given state. Through development of local Medicare policy, MACs and fiscal intermediaries, they determine whether a procedure is considered appropriate in an attempt to clarify specific coverage guidelines, particularly when a carrier has identified overutilization of a procedure. The health insurance claim number and ID card at the bottom of page 170. This type of coding allows the health insurance professional to look at the patient's ID card and immediately determine what the coverage is. The prefix or suffix may change, but the Social Security number will not. Your Medicare ID card at the top right-hand column of 170. Your patient is to present this card. The information on the front tells you what they are enrolled in. If they have both a Medicare and Medigap policy, they will have two cards, and they should present both cards to you when they come into the office. Over on page 171, Medicare billing. When billing a claim to Medicare, we must use the Medicare fee schedule. CMS publishes an updated Medicare physician fee schedule every year. The Medicare fee schedule is based on a resource-based relative value system. This means that each of the payment values is found within a range of payments. Your Medicare physician fee schedules will vary from one region to another. I want you to take a look at table 9.8 and 9.9 in your textbook on page 171. You will see more often than not that your Medicare ID cards will have these codes after the ID number. The ones you see the most are usually A, D, or W. Those are the ones I see the most. Your Medicare PAR providers. PAR provider is someone who is participating with Medicare. They are the supplier who has signed a contract with Medicare. And so what are the advantages of being a participating provider? It is that the Medicare fee schedule is 5% higher than that of non-PARs. And they are provided with toll-free lines if they submit claims electronically. And their names are listed in the Medicare Participating Physician Supply Directory, which is furnished to your senior citizen groups. Your Medicare non-PARs, they can accept Medicare's approved amount on a case-by-case basis. If amount is approved, it's not accepted. The beneficiary pays the full billed amount, and the full billed amount equals Medicare's limiting charge, which is usually 115% of the allowed amount in the fee schedule. Over on page 172, determining what fee to charge. Know how to interpret the Medicare fee schedule so that you can determine the correct fee to charge the patient. When you are filing Medicare claims, it is mandatory to submit them electronically. There are HIPAA claim standards to follow, and there is a version 5010 file that must be used. There are some exceptions to the rules. Small provider claims, dental claims, disruption in electricity or communication connection outside a provider's control, claims from providers submitting less than 10 claims per month. These are all exceptions. Status request and response on page 174. They list several options for you to obtain claim status information from the Medicare contractors. There is a deadline for filing Medicare claims over on page 175. It's usually a 12 months period. Timely filing of your claims must be done within 1 year of the date of services. When you're using the CMS 1500 form for Medicare claims, they tell you over on the page 175 at the bottom all the different things that you should not be doing or following when you're submitting those claims. To complete a CMS 1500 form, make sure you use 10 or 12 pitch fonts. Do not mix the fonts on the same form, and do not use italics or script. Avoid using old or worn print bands, and do not use dollar signs, decimals, or punctuation. Over on page 176, it finishes up and tells you the final steps to complete a CMS 1500 form. When you're completing a Medigap claim, you want to make sure that in blocks 9 through 9D that you have the insurance information related to the Medigap plan. With the Medicare secondary payer and insurance primary to Medicare, you want to make sure the group health plan coverage is on there, no fault or other liability insurance. These are the types that you'll be looking for. To complete the Medicare secondary policy claims, it tells you there in the book, make sure the name and address of the primary insurer, subscriber policy number, provider of services, and it gives you in table 9-10 the blocks and how to make sure that those are filled in correctly. If you are to submit paper claims, if you were to submit paper claims, the CMS 1500 form must indicate the name and policy number of the beneficiary, primary insurance in blocks 11 through 11C. On page 178, you'll see table 9-11, and it gives you block 11A through 11D and how those should be filled out. Your Medigap crossover program. This is a process which is mandated by the Social Security Act. It's activated when a participating Medicare provider includes a specific identifier on the beneficiary's claim and payment benefits are assigned to that provider. Your Medicare and Medicaid crossover claims on page 179. There are some modifications that must be made on the CMS 1500 form to indicate the dual eligible beneficiaries. We send the claim to Medicare first, and then they determine the liability portion of the charges. Then the claim is crossed over to Medicaid, who in turn will pay a small portion of what they will take responsibility for. So let's just look at a Medicare summary notice at the bottom of page 179. This is going to list the services that were received, the name of the provider, the total amount billed by the provider. You'll actually see an example of this on page 180. Take a look at page 180. And 181. This is a really good example of what the recipient sees in when we bill their insurance. This is what they get. Over on page 182, your Medicare remittance advices, you have the SPRs and the ERAs. The SPRs are your standard paper remittance. Your ERAs are your electronic remittance. If you are enrolling in the electronic remittance and EFT, you must contact your software vendor to determine whether ERA capability is available for your facility. Then if it is, you must complete the ERA enrollment form, and then your payments from Medicare may be automatically deposited to a provider's designated bank account using electronic fund transfer. You look over on page 183, that is a good example of how a Medicare remit looks. Medicare audits and appeals. On page 184, there are two broad categories of audits. There are the prepayment audits and the post-payment audits. What are some of your audit triggers? Downcoding is one of them. Using the same code repeatedly, and patient complaints. Recovery Audit Contractor Program, also known as RAC, is a result of your Medicare Modernization Act and the Tax Relief and Healthcare Act of 2006. Page 187, Appeals Fee for Service Claims. Your Medicare regulations allow your providers and beneficiaries who are dissatisfied with Medicare's payment determination to request that the determination be reconsidered. Through the appeals process, Medicare attempts to ensure that the correct payment is made or a clear and adequate explanation is given supporting non-payment. Your problem claims are not given appeal rights and they are returned as unprocessable. The provider then will have two options for correcting that claim. They can submit an entirely new claim via paper or electronic, or submit corrections in writing. Over on page 188, there are 5 levels of appeal action that are available to if the provider and or beneficiary disagrees with a coverage or payment decision by Medicare. Over on page 189, this is the appeals process for Medicare management. Your beneficiary complaint response program at the bottom of 189. This is for the complaints that are made by Medicare beneficiaries. They can either be made in writing or by telephone. NODMAR reviews, or HINN, Hospital Issued Notice of Non-Coverage and Notice of Discharge and Medicare Appeal Rights. HINN is the Hospital Issued Notice of Non-Coverage. NODMAR is Notice of Discharge and Medicare Appeal Rights. The purpose of NODMAR is to review and ensure that HINN is correct and that the patient is not being discharged prematurely from care. The Center for Medicare and Medicaid Innovation. This is also part of the Affordable Care Act. Your CMS created the Center for Medicare and Medicaid Innovation. There are successful models that meet cost and quality tests that may be expanded to all Medicare, Medicaid, or CHIP beneficiaries. The physician review of medical records. This is a peer review. It's an important component of the quality of care oversight provided by Medicare QIOs and external review, quality review organizations. Your PQRS, or Physician Quality Reporting Service, provides a financial incentive to eligible professionals, or EPs, for voluntarily reporting data on specific quality measures for covered services furnished to Medicare beneficiaries. The Medicare billing fraud. To recognize Medicare billing fraud, you have to know the rules, and these rules are complex, confusing, and constantly changing. So it is possible to interpret a rule. This happens a lot, so you must be careful. And what I meant was it's possible to misinterpret a rule. It may initially appear as if the individual is guilty of Medicare billing fraud when what actually happened was a failure to understand a regulation. Reporting Medicare billing fraud, you have an obligation to stop or report fraud. The Medicare hotline, follow your facility's procedure manual, and make sure you look online. Your Clinical Laboratory Improvement Amendments Program on page 191, this is CLIA. This regulates the quality standards for all laboratory testing done on humans. To enroll in the program, you must register by completing an application. There are fees that are structured according to this type of certificate requested. There are preliminary measures that must be taken. Not every practice has this application and registration. It just, you have to know your physician and are they going to be utilizing these types of services. All right, any questions on Chapter 9?
No.
You mean that wasn't overwhelming?
It was definitely long, so I'll have to go back and, read it over, summary checkpoints. But
Yes, that's what I would suggest, is read your summary checkpoints again before you try reading the chapter again.
yeah.
Why don't we take a quick 5 minutes here, and we'll come back and finish up, get through hopefully the next 3 chapters. Okay?
Okay. chapter.
This Medicaid is actually very so lengthy. Yeah. Medicaid is one. Actually, is you live in Gardner or
I live in Litchfield.
oh, Litchfield?
Where do you live?
Holloway.
Oh, yeah.
My husband works here in Gardner.
At the high school?
No, Right Aid Pharmacy.
Oh, okay.
Have you been there?
Well, I don't use a pharmacy there, but I
Oh, you never.
I go in there
okay.
often. Yeah.
Yeah. Yeah, he's been there past 10 years, I guess.
Wow.
8, 9 years. There's codes coming up here. My God. ICD-10.
I think it took almost an hour for just that one chapter. So I don't know if we'll get through 3 more because this one's just as long.
Oh, 2 more is there for today, right? Oh, 3.
Yeah, we're supposed to go up to chapter 12 tonight.
All right. Is everyone back?
Yep.
Okay. So, Chapter 10, Military Carriers. Okay. Your military carriers, the health programs, the health system, all of that. The military health system, MHS, over on page 197, Chapter 10. In 1884, your officers and soldiers were treated free of charge when at all possible. In World War II, creation of the Emergency Maternal and Infant Care Program came into effect. In 1956, during the Korean War, Dependents Medical Care Act. And then in 1966, amendments became Chapt. The federal government has provided health care for the military from the earliest years of U.S. history. So what is TRICARE? TRICARE serves nearly 10 million beneficiaries worldwide, including the National Guard and reserve members, retirees, their families, survivors, and certain former spouses. As you see at the top of the page on 197, the TRICARE program is across the United States and overseas. It is managed by TRICARE Management Activity, TMA, under the authority of the U.S. Assistant Secretary of Defense. TRICARE is organized into the 6 geographic parts that you see in the map, and 3 areas are overseas. Each region and area has its own regional office and regional contractor, and each region and area will provide oversight of the operations and the health plans administered at the regional level. They manage the contracts with the regional contractors. They support the military treatment facility commanders. They develop business plans for non-MTF areas, which are your remote areas, and they fund regional initiatives to enhance and improve the delivery of the health care. So the MHS includes military treatment facilities and various programs care within the civilian population. The TRICARE regional contractors, as I mentioned earlier, each region is headed by a regional director, and they are responsible for all of the healthcare delivery activities within the region. They also provide oversight of regional operations and health plan administration, along with the management of those healthcare support contracts. So who is eligible for TRICARE on page 198? The beneficiaries, those are your TRICARE eligible individuals. The sponsor, the service member, whether they are active duty, retired, or deceased. And the individual must also be registered in DEERS. DEERS is the Defense Enrollment Eligibility Reporting System. It's a computerized database that lists all of the active and retired military service members, their family members, and others who are eligible for the military benefits. Some of the TRICARE eligible categories: These are individuals that are classified into some of the following main categories. And they show those there at the top of page 199. When someone wants to update personal information, it is the spouse's responsibility to ensure that the family members are registered in DEERS correctly and that all status information is kept current. Who is not eligible for TRICARE? Usually the individuals who are younger than 65 who are eligible for Medicare because of a disability or end-stage renal disease. They may retain eligibility until they're 65, but they have to be enrolled in Medicare Part B. Parents and parents-in-law of active duty or uniform service retirees or of deceased active duty or retirees may be able to receive treatment in military facilities if space permits. Losing TRICARE eligibility, it may end for some of the following reasons, as they list in your book. If a TRICARE member loses their TRICARE eligibility, they will automatically receive a certificate of credible coverage, which will serve as evidence of prior health care coverage under TRICARE, so that the individual cannot be excluded from a new health plan because of any pre-existing conditions. TRICARE program options on page 199. Look at the table 10-1 on page 200. See the details for the different program options?
Yep.
Okay. And then if you look at page 201, table 10-2, you'll see the program information, the type of program, the enrollee, the fees, and the provider choices. That's really the best way to explain the program options. TRICARE Overseas Program, page 199, and the Young Adult Program. These provide health benefits to beneficiaries who are living and traveling overseas while they are eligible for TRICARE. What does TRICARE pay? They include medical and psychological services and supplies that are considered appropriate care and are generally accepted by qualified professionals to be reasonable and adequate for the diagnosis and treatment of illness, injury, pregnancy, mental disorders, and well child care. Champ's maximum allowable charge. Over on page 200. So how does TRICARE establish their covered charges? Basically, they calculate the allowable charge by looking at all of the professional provider fees for the same or similar services that are nationwide over the past year, and then they make adjustments for specific localities, and that's how they come up with their covered charges, their fees for their covered charges. If you look on page 202 at figure 10-2, there are three basic program options under TRICARE: your standard, your extra, and your prime. The extra and prime are available only in areas where TRICARE is in operation and a civilian provider network has been established to support the program. Your active duty, guard, and reserve members are automatically enrolled in TRICARE Prime. Your TRICARE dental program. This is if the health insurance isn't sure whether TRICARE covers a particular service or supply. You want to make sure that you contact the beneficiary counseling and assistant coordinator or the health benefits advisor or your TRICARE support center or even the TRICARE contractor. You want to make sure that what is your coverage under this program. The TRICARE standard non-availability statement over on the bottom right of 202. If treatment is not available at an MTF, your military personnel and TRICARE eligible dependents must, under certain circumstances, obtain an NAS indicating that care is not available from the medical treatment facility. Even though an outpatient NAS is no longer required for outpatient services, except in certain situations like maternity, the beneficiary must obtain advance authorization to undergo any procedures. Your supplemental TRICARE programs over on page 203. Exceptional Family Member Program, EFMP, provides care for dependents with special needs. The Extended Care Health Option, ECHO, TRICARE Plus. These are some of the supplemental programs. Your TRICARE and other health insurance, page 204. It may also be called double coverage or coordination of benefits. We saw this back in the Medicare chapter where they had Medicare and another insurance. Your TRICARE standard supplemental insurance. These are similar to your Medicare supplemental policies in that these secondary plans are specifically designed to supplement that TRICARE standard benefit. Your TRICARE for Life, or TFL. Medicare is the primary insurer, but TRICARE acts as the secondary payer, minimizing your out-of-pocket expenses. When you are verifying TRICARE eligibility, patients who claim to be eligible for benefits under one of these programs should have their eligibility verified immediately. Just because you have a card doesn't mean that you're covered. So look at page 205, box 10-2. This tells you how to interpret their card and what does it mean and what coverage do they have. Over on page 206, they give you some examples of ID cards. Always check your expiration dates. Your TRICARE authorized providers. Your authorized provider must have a valid state license and a national organization accreditation. The network providers are usually TRICARE authorized providers. Your participating non-network providers agree to file claims for the beneficiary and accept payment directly from TRICARE. And it's also based on TRICARE's maximum allowable. Your non-participating providers do not agree to accept TRICARE maximum allowable, and they do not have to file beneficiary claims. Your TRICARE participating providers, your TRICARE
There-
PARs. Yes.
I have a question. This TRICARE, do they pay premium? It's same as private insurance and group insurance, like managed care and Medicare.
Yes,
Like
it comes right out of the pay of the beneficiary. So they would still
like
have a
copay. Oh.
yes, they still would have co-pays and stuff. Depending on the type of plan, standard, prime, or whatever, they still would have, you know, a copay or a percentage of a coinsurance. Cost sharing over on page 207. Cost sharing. The beneficiaries are responsible for cost shares and deductible for care that is covered under TRICARE standard. The CAT cap applies only to the allowable charges for covered services and does not apply to services that are not covered or to the total amount of what non-par providers may charge above the TAC. So it's important that you keep your TRICARE changes, that you keep current on your TRICARE changes because they do make changes year to year, just like all the other payers do. The TRICARE coding and payment system, they follow the Centers for Medicare and Medicaid annual coding and reimbursement. There are annual updates for TRICARE. There are new codes that are usually implemented on January 1st to align with your Medicare implementation. The claims processing, who submits claims? The provider, the patient. There is a 30-day deadline from the date of service to as soon as possible after the service is rendered. When you're submitting paper claims, the TRICARE network providers are required to submit claims electronically. Patients who file their own claims must use Form 2642. Your non-network providers, they have the option to submit paper claims. Like we saw in Medicare, the advantages to submitting electronic claims: saves money, saves time, improves cash flow. The deadline for submitting claims on page 210. You want to submit TRICARE claims within 30 days from the date of service or as soon as possible. The sooner the TRICARE contractor receives the claim forms and other papers, the sooner the claim can get paid. The TRICARE EOB, explanation of benefits. This shows what the provider billed, the TRICARE allowable charge at the time of care, how much of the patient's annual deductible has been met, how much the patient has paid toward the annual cost cap, the patient's cost share for the care, and so on is listed on page 211. Chapt VA on page 211. This is the Civilian Health and Medical Program of the Department of Veterans Affairs. It is a federal healthcare benefit program administered by the Department of Veterans Affairs. How is it different from TRICARE? It is a VA-run program for eligible survivors and dependents, whereas TRICARE is regionally run DoD program serving your active duty retirees and their families. The Chapt VA eligibility, the dependents of veterans with total and permanent service-connected disability, survivors of veterans who died from service-connected conditions or who at death were permanently and totally disabled from a service-connected condition, survivors of persons who died in the line of duty, not due to misconduct, and who are not otherwise entitled to TRICARE benefits. Extending the eligibility. In addition to the eligibility criteria that we just outlined, individuals must meet the conditions that are shown here in order for benefits to be extended past 65 years of age. If you look on page 214, you'll see how you can identify a beneficiary. They show you a card there. Every Chapt VA beneficiary has a member ID card. Your eligibility for them can also be confirmed with the use of the IVR system. Chapt VA benefits and cost sharing. Although many veterans qualify for cost-free healthcare services on the basis of their service-connected condition or other qualifying factor, most are required to complete an annual financial assessment or means test to determine whether they qualify for cost-free services. Chapt VA In-House Treatment Initiative. This is a voluntary program that allows the Chapt VA beneficiary to be treated at participating VA medical centers with no out-of-pocket cost. So every VA medical center that participates in this program offers different services based on unused capacity. The Meds by Mail program. This is prescription medications by mail. So just to summarize, Chapt VA costs, beneficiaries pay nothing to have it. They pay only when they use it, and then payment goes to the provider, not to the VA. The qualifying services here are going to be your inpatient, outpatient, mental health care, substance abuse, prescription meds, and hospice. There is an annual deductible, $50 for an individual, $100 for a family. The cost sharing or co-payment, the beneficiary pays 25% of the allowable charges unless the care is provided by the VA. $3,000 of that is an annual cap for catastrophic, and they have the freedom to choose any licensed provider. They do have a prescription drug benefit. The Chapt VA offers a more cost-effective prescription drug benefit than the Medicare Part D, and they do so without a monthly premium. The Chapt VA TRICARE Connection. The Chapt VA provides benefits to eligible family members of veterans who have been permanently disabled, declared 100% permanently disabled from service-connected conditions, or they are survivors of veterans who died from service-connected conditions, or survivors of service members who died in the line of duty who are not otherwise entitled to TRICARE benefits. Over on 217, the types of health insurance plans primary to Chapt VA would be State Victims of Crime Compensation Program, Indian Health Services, Workers' Compensation Claim, and Injury Due to Automobile Accident. For coverage outside of the United States, over on page 218, there are countries excluded from Chapt VA coverage. That would be Iraq, North Korea, and Cuba. Chapt VA does not pay for any medical care for the treatment of a work-related or illness or injury when the benefits are available under a workers' compensation program. Remember we talked about earlier having dual coverage. When a beneficiary is eligible for health care benefits under both Medicare and Chapt VA, Medicare would be the primary payer. Chapt VA paying HMO and PPO copays, they do not pay for out-of-network care. So if your Chapt VA eligible beneficiary has an HMO or a PPO plan, the Chapt VA pays any copayments required under those plans for only Chapt VA covered services up to the Chapt VA allowable amount. So very similar to your Medicare and secondary insurance. Chapt VA policy on balance billing. Providers who accept Chapt VA patients also must accept the Chapt VA allowable rate as payment in full and cannot balance bill. Chapt VA for Life, CFL. Much like your Medigap insurance, CFL will pick up where Medicare leaves off. The CFL will pay the coinsurance and deductibles, but does not pay the monthly Medicare Part B premium. Chapt VA for Life eligibility. A spouse loses eligibility for CLF if he or she divorces the veteran. A widow or widower who remarries also loses eligibility. However, if the remarriage terminates, his or her eligibility is reinstated. If a service or procedure is covered by both Medicare and CFL, the beneficiary usually will have no out-of-pocket expenses. To file your Chapt VA claims, over on the right-hand side of 219, providers accepting assignment for Chapt VA claims must submit claims for the beneficiaries. The beneficiaries who receive treatment from non-PARs usually are required to submit their own claims. By law, Chapt VA is always the secondary payer, except to Medicaid and Chapt VA supplemental policies. HIPAA and military insurers, page 221, 222. All of your medical treatment facilities have implemented the privacy rules of HIPAA. Privacy officers and privacy patient advocates should be available, and the privacy notice available on the TRICARE website. Any questions regarding TRICARE, ladies?
No, I think you blew through it.
Is children's eligible like till 26 for TRICARE and Chapt?
Say that again?
Like dependent children, are they eligible till 26?
Till 23 if they're enrolled full-time in school.
Yeah. Or 20? No, 23 or 26?
There was something
26.
26.
I think it's 23, but let me double check. It is the Chapt VA Dependent Coverage Extension Act on page 211 allows the VA to extend coverage for veteran dependents to the age of 26 up from the current age of 18 or 23 if a full-time student. When a Chapt VA beneficiary turns 65 years old and enrolls in Medicare A and B, blah, blah, blah. So it's 26, just like regular insurance now. But they have to be enrolled as a full-time student. All right, any questions? I think the summary checkpoints will actually cover that rather nicely if you want to review those for any reason. Okay. We're probably only going to get through 11. Let's take a look. Miscellaneous carriers. These are your workers' comp and disability insurance. All right, let's start with workers' comp on page 228. The type of insurance that's regulated by state law is workers' comp. It pays your medical expenses and partial loss of wages for workers who are injured on the job or become ill as a result of the job-related circumstance. So how does it work? Each state sets up its own workers' compensation laws and regulations. Most of your American workers are covered by your workers' compensation laws. The employer usually pays premiums. So let's give you a little bit of history. It began in Germany in the late 1800s to take care of injured workers. When workers' compensation was proposed in the U.S., companies agreed to pay the premiums for the insurance that protected the workers, and the workers would give up the right to sue the employer for damages resulting from a job-related illness or injury. Workers' compensation is not considered a benefit, rather it is a legally mandated right of the worker. Your companies who meet these specific state requirements must provide workers' compensation for all of their employees. There is federal legislation. You'll see on page 228 and 229, those acts are listed. Your Federal Employment Compensation Act, Energy Employees Occupational Illness Compensation Program Act, Longshore and Harbor Workers Compensation Act, Black Lung Benefit Act, Federal Employment Liability Act, and Merchant Marine Act. Workers' compensation eligibility, blah, 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 sorry. Benefits are awarded only for disability or death occurring while the employee was in the process of performing those lawful duties. There are some exemptions, such as independent contractors, commissioned employees, employers with a limited number of employees depending on state statutes, executive officers, family members, sole proprietors, casual employees, volunteers, your part-time domestic employees, agricultural workers. No-fault insurance. Workers' comp insurance is no-fault insurance. There are 4 major benefits: medical expenses, disability pay, vocational rehab, and death benefits. Your medical expenses will cover the hospitalization, doctor's visits, and any necessary medical treatment. Disability pay can either be temporary or permanent if it is determined that the worker will never fully recover. Voc rehab, this is retraining for workers to allow them to enter into a new trade or business. It's always also pays for needed physical therapy, and there are death benefits paid to surviving dependents. The coming and going rule. Inquiry as to whether the coming and going rule applies to a particular situation should be made before simply ruling out the possibility of coverage for an accident that occurred during a worker's commute to or from work. Coverage extends to travel when the scope of the employee's duties include travel or when the employee is running an errand for the employer. Denial of benefits. Employees can appeal denied benefits and or resort to litigation. The appeals process will differ by state. It is started by contacting your appropriate state agency or by hiring a lawyer. And if the denial becomes final, the patient is responsible for payment of medical bills. The time limits. Each state has a certain time limit to file appeals. Traumatic claims appeals must be brought within a time frame that runs from the date of the accident, date of the last medical treatment, or date of the last payment of benefits. delayed illnesses. In cases where a job-related disease does not appear immediate, like lung cancer, toxic disease, mesothelioma, the time limit may actually extend from the date of the last exposure, the date of the first symptoms of the disease, or the date the diagnosis was determined. Your workers' compensation claim process. Employees who are injured or suspect they have been injured or have contracted a disease they believe is related to their job, they should tell their employer as soon as possible. Failure to do so and seek timely medical treatment within the workers' compensation network may cause a delay in claim processing and perhaps even a denial of benefits. Physician's role is to diagnose and treat work-related injuries or illnesses. You also need to provide claims administrators' opinions in response to specific medical and legal questions about work-related injuries or illnesses. Some of the typical questions the physician may be asking you regarding the nature of the injury, or some of the questions the physician might be asked, is the injury or illness work-related? Is the condition permanent and stationary? What is the extent of the disability? Can the employee return to his or her usual and customary work assignment, and when? Does he or she need some type of accommodations? Does he or she need to be retrained for a new job? Will the employee require access to future medical treatment for the condition? So how does the doctor determine disability? There are several types of disability, and I want you to refer to your text on page 234 for a complete explanation of each one. If an employee accidentally shoots a nail through his hand or her hand, into what classification of disability would the employee most likely fall? What do you think, Kelsey?
Temporary disability.
Yes.
Temporary partial.
Now, if the employer does not offer light duty, it could become permanent disability. Would you agree?
Yeah.
Yeah.
Right. So if an employee loses both hands in an explosion, what classification of disability would he or she most likely fall into for that one?
Permanent?
Yes, total permanent disability. So voc rehab, when employees cannot return to their previous job due to a workers' comp injury or illness, they are often entitled to voc rehab services, if it is reasonable to assume that these individuals can be trained for some alternative type of employment. So the goal is always to return the injured worker to some sort of suitable, gainful employment that he or she can reasonably achieve, and that offers an opportunity for them to restore them to maximal self-support as soon as what they determine practical and near possible, as the patient was prior to an accident. Now, you and I both know that that doesn't always happen very well, correct? Okay. Waiting periods. Your workers' compensation benefits normally do not begin immediately. There are waiting periods that vary from state to state, and most states allow for retroactive compensation. Claim forms. There are no universal forms for filing workers' comp claims. Many of your insurance carriers have their own forms. You must submit it on the CMS 1500 form, and multiple copies of the reports are needed for proper distribution. Because you also have what is considered to be a M1 form. Have you all heard of M1 forms?
No.
M1 form is reporting reporting a work-related injury. It has to be filled out, and it actually has to be filled out in triplicate. It goes to 3 different places: the employer, the employee, and the insurance company. All right.
So they're using CMS 1500. Is there any place that says workers' comp? Like in
Any what?
Is there any area that says workers' comp in 100?
No. You would
Then
still
how?
fill it out with the insurance, and in the middle of the form, I think it's box 10, they ask if it's an accident, and you would indicate if it's other employment or something else. And that's how we would know if it is an accident. Progress reports, your initial attending physician fills out a report, and then there's periodic progress reports that must be filled out and returned to those 3 places that I mentioned: the employer, the employee, and the insurance company. If you have special billing notes, use the appropriate fee schedule when you bill your workers' comp claims. A provider cannot bill the patient as long as the workers' comp claim is pending. Balance billing is not allowed on workers' comp claims, and if the claim is denied and after all the appeals are exhausted, the provider can bill the patient or his or her health insurance carrier. Workers' comp and managed care. This is alternative to the traditional approach. The managed care system provides medical care to the injured employees. This usually ends up being a cost saving to the employer. It just depends what state you're in and do they offer that. HIPAA and workers' comp is very similar to HIPAA and Medicare, HIPAA and TRICARE. The privacy rule, though, does not apply to workers' comp insurers, their administrative agencies, or employers. Basically, if the workers' comp insurer wants reports and information, we have to hand it over to them, but we have to still have a signed release. Rights of access. Workers' comp patients may or may not be required to sign a release of information form. So for this reason, it is advised that workers' comp records be kept separate from other health records. Workers' compensation fraud. Report suspected fraud within a reasonable time, usually 30 days. Disability income insurance, there's 2 types: private and employer sponsored. There are 2 types of coverage: disability coverage, short-term and long-term. Your short-term disability provides income for the early part of a disability, typically 2 weeks up to 2 years. And then long-term disability, which helps replace income for a longer period, up to 5 years or until the disabled person turns 65. When we are defining disability, it is the inability to perform in the occupation or job that an individual was doing before the disability occurred. So there's two types: own occupation policies and modified own occupation policies. The inability to perform any occupation for which the worker is suited by education and experience. As I mentioned, short-term disability will pay a percentage of that person's wages for temporary time. Workers usually begin receiving money within 1 to 14 days of becoming sick or disabled, and it will be there will be various employer restrictions, such as using sick days. Your long-term disability pays monthly amount to help cover expenses when an individual is unable to perform his or her job function. There are two types: no cancelable and guaranteed renewable. Your disability claims process, there are certain responsibilities that both the employee and the employer must attend to allow for the process to work efficiently and effectively. So the employee's responsibility is to notify the proper party that he or she intends to file a disability claim by submitting a claim request. The employer's responsibility is to provide detailed information, such as the type of coverage, policy, and other identifying numbers and descriptions. The attending physician statement needs to determine the type of disability, and the attending physician's report needs to have the diagnosis, the first day the individual was unable to work, whether illness or injury is work-related, what is the nature of the treatment or suggested treatment, and restrictions and/or limitations. Health insurance professionals' role is to see that everything possible is done to facilitate the claims process. The federal disability programs, you have them listed in your book. On page 243. Eligibility. A person may receive benefits from more than one program if he or she meets all of the eligibility requirements. Defining disability under the federal law. There's significant difficulty here because the person has difficulty performing certain day-to-day functions as a result of that health condition or impairment. It will vary by age. Obviously, the younger you are, hopefully you'll be able to bounce back quicker and not be as disabled. And the older you are, it may simply be the inability to carry out routine daily tasks. The ADA, or Americans with Disabilities Act, the intent of this act is to protect the civil rights of persons with disabilities. The criteria for disability under the ADA is individual has a physical or mental impairment limiting one or more of his or her major life activities. There is a record of such an impairment, and the individual is regarded as having that impairment. Social Security disability is the primary federal insurance program that protects workers from loss of income due to disability. It also provides monthly cash benefits to disabled workers under age 65 and to certain of their dependents. It is intended for workers who retire before the age of 65 because of a disability. The eligibility criteria, there's two here. They must have worked enough Social Security covering their work quarters, and they must have an impairment that makes them unable to do their previous work or any other kind of substantial financial gainful activity. To receive SSDI, the dependent coverage and benefits are offered to certain qualifying individuals. They show you in your book. They must be on their own as disabled workers, as widows or widowers of those insured individuals, or as adults age 18 through 64. SSI is supplemental security income. It provides monthly cash payments to low-income, age, blind, and disabled persons, and it was established in 1972 as an amendment to the Social Security Act. To be eligible, a person must meet the financial means test. If they are under 65, they must meet both disability and financial criteria. Those who are 65 or over need only to meet the financial means test. Determining disability for adults, identical to SSDI program. State disability programs, California, Hawaii, New Jersey, New York, Rhode Island, and Puerto Rico. Centers for Disease Control and Prevention supports 18 state-based disability and health programs that ensures your disabled individuals are included in these ongoing state disease prevention, health promotion, and emergency response activities. The Ticket to Work program and self-sufficiency program on page 247. This is a voluntary program giving certain individuals with disabilities a greater choice in services they need to help them keep working or get back to work. The participant will receive a ticket explaining the program. They take that ticket to Approved Employment Network to receive services. To file for SSI or SSDI, there are many steps in this application progress. There are multiple roles when filing for this disability. There's a patient's role, a provider's role, and the health insurance professional's role. And lastly, the health insurance professional role, some of the additional responsibilities would be to get patient authorization to release information, acquire necessary information for claim processing, ensure that the attending physician forms are completed and signed, photocopying all of the patient's health records, maintaining a well-documented record, and answering the patient's questions. Do you ladies have any questions?
No, not right now.
Okay, your brain tired?
Yeah.
Yeah. Okay, so we didn't get through 12, but that's diagnostic coding. I'm actually going to go over that quickly next week. What I will say to you, let me just take a look here. We'll probably do a couple on Google next week, just so I can show you how to Google them.
I mean, you're gonna show us like from your screen now?
Yep.
Because even today and last week we could see you, but this week we can't.
You can't see me at all?
No, it's just a frozen picture of you.
Okay, but at least you can see me.
Yeah.
It's not just
So hopefully it'll work next week.
Okay, so for next week, let's see, we didn't do 12, so 13, 14.
Then next week we'll bring that ICD-9 book.
Say that again, Anita.
Next week, do we have to get the ICD-9 book or?
No, you don't need the ICD-9 book. You do not need the ICD-9 book at all. I'm going to show you how to Google stuff on Google.
Oh, okay.
Okay, so why don't we for next week do 13, 14, and 15?
But what about 12?
Well, you already read it, correct?
No, I haven't read chapter 12.
Okay. So read chapter 12, 13, 14, and 15.
Okay.
For chapter 12, as far as homework, let me take a look. Okay, on page 256, you can't do number 2. On All right, on page 261, you can do 2 and 4. Any question that asks you to find a code, don't do it. Yeah, like 264, you can do 2 and 4 because the answers will be in the book. On 266, you can do 2 and 4. $269. You should be able to do 2 and 4 because it's not a code. $270, 2, 4, and 6. And down at the bottom, number 2. $277, 2 and 4. You can't, okay, on 277 on the right-hand column, you can't do those, so we'll do those in class because they want you to find the code. You can tell me the main term, but you can't locate the code yet, so we'll do that in class.
Like, do we have to write down in any other place this homework?
You just use a notebook to write your answers down. That's all.
Okay.
Same thing on 284. You can't do those codes. You can tell me what the main terms are. And 287, you can do 2 and 4. $289, 2 and 4. $290, you can't do. Over in the right-hand column, you can answer number 2. 291, you can answer number 2. And that should be it for 12.
So are we doing the what did you learn for chapter 9 through 11 as well?
Yes.
Just the even numbers?
Yep. I wanted to go through 12 before we lost video.
Yep.
So just the even numbers. So 12, 13, 14, 15 for next week. Read those. Do the answers for 9 through 12, even numbers. and any Evolve exams for those chapters, except 12. Sound like a plan, ladies?
Yeah, I haven't attempted the from first chapter. By next
Okay.
week, maybe I'll try to do it.
That's fine.
Okay.
That's fine. Any questions?
You said don't do chapter 12 exam online?
Right.
Okay.
Yep. Just 9 through 11. Okay. Have a great night
You too. Thanks.
and a good weekend.
You too.